Welcome to another episode of the Zach Hiley Show. Today, I have the honor of being with Dr. Charles Yeo. So a little bit about Dr. Charles Yeo. So Dr. Charles Yeo is a hepatopancreaticobiliary surgeon here at Jefferson. He was born in East Orange, New Jersey, and attended Spring Valley Senior High School in Spring Valley, New York. He received his undergraduate degree from Princeton University in 1975, summa cum laude with an A.B. in biochemistry. Dr. Yeo graduated in 1979 from Johns Hopkins University School of Medicine, being awarded the Upjohn Achievement Award, and he was elected to the Alpha Omega Alpha and Phi Beta Kappa. While completing his internship and residency in general surgery at Johns Hopkins Hospital, he pursued a one-year research fellowship at the S.U.N.Y. Downstate Medical Center in Brooklyn, New York. Dr. Yeo joined the faculty of the Johns Hopkins University as an instructor and assistant chief of service in the Department of Surgery in 1985 and rose to the rank of professor of surgery in 1996. In 1997, he became professor in the Department of Oncology. Dr. Yeo directed the Pancreatic Center Interdisciplinary Working Group at Johns Hopkins and served as the surgical clerkship coordinator and surgical curriculum consultant. In 2002, Dr. Yeo was named to an endowed chair at Johns Hopkins, becoming the inaugural John L. Cameron, M.D., Professor of Alimentary Tract Diseases. On October 1, 2005, Dr. Yeo was named the 8th Samuel D. Gross Professor and assumed the chairmanship of the Department of Surgery at Jefferson, now Sidney Kimmel, Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania. He currently serves on the Board of Trustees of the Thomas Jefferson University Hospitals and as the Senior Vice President and Chair of Enterprise Surgery for Jefferson Health, an 18-hospital system. Dr. Yeo has authored over 650 peer-reviewed scientific papers, 120 book chapters, and over 24 books or monographs. Dr. Yeo is also known as the Whipple King, having completed over 1,840 Whipple procedures and treated over 3,000 patients with pancreatic and related cancers. Thank you so much, Dr. Yeo, for taking the time to speak with me today.
Zach, I'm delighted to be here. Thank you for the invitation.
It's great to have you. And I also wanted to mention all proceeds from this episode go to the Friends Against Pancreatic Cancer Fund and the Doctors Francis and E. Rosado Fund for Surgical Education and Research. So the first question I want to start out with is, what is hepatopancreaticobiliary surgery? Did I even say that right?
You said it well, and it's exactly what it says. I think when we go into medical school, we learn a new language. And the language we learn is sort of the scientific medical language. So HPB surgery, which is what you asked about, hepato deals with the liver, pancreatico deals with the pancreas, and biliary obviously deals with the bile ducts. So this is largely surgery that involves the right upper quadrant of the abdomen.
Got it. And you're known so well for this thing called the Whipple Procedure. Can you tell me a little bit about that? I have no idea what the Whipple is.
So the Whipple procedure is a complex alimentary tract operation that's used to remove the head, neck, uncinate process of the pancreas. It's typically performed for patients that have pancreatic cancer or any of the other 3 periampullary tumors, and that involves cancer of the ampulla, cancer of the duodenum, or cancer of the distal bile duct. It's a complex operation that is divided into 2 phases or stages. First is the extirpative phase, where you actually remove the tumor. And second is the reconstructive phase, where you reconstruct the GI tract, in a sense, redo the plumbing of the GI tract so the patient can eat and drink normally.
Wow. How long does this procedure usually take?
Well, yesterday's case on a 310-pound gentleman took about 10 hours, but in someone of normal body habitus, say a Philadelphian who is 6 foot tall and weighs maybe 180 pounds, the operation can be done safely in 5, 6, or 7 hours.
And this is maybe a naive question, but why is surgery more difficult on people who have a bigger body habitus or takes longer?
Yeah, because we do the operation by making an incision. People that are incredibly heavy or morbidly obese have a large abdominal pannus. There's literally inches and inches of what we jokingly call insulation. Others would call adipose tissue or fat to get through. And then we have to change how we do the operation. In a sense, we have to use longer instruments, and we have to use more complex retraction systems to hold the abdominal wall open so that we can get down and do the operation.
And is there a greater chance of morbidity and mortality with obese patients?
Absolutely. And that's true not only with the Whipple operation, but quite honestly, really, with any surgical procedure. The patients have more difficulty with postoperative ambulation. They have a higher risk of VTE, venous thromboembolism. They have a higher risk of pneumonia. And they have a higher risk of superficial wound infection, problems with healing the wound sort of from the skin down, because there's just more tissue there, and that tissue gets devascularized, and there's more space for infection to set in.
And the Whipple procedure, this is an open procedure, as in you're making an incision and you're not using kind of any cameras or anything like this.
When Dr. Alan Oldfather Whipple first reported his first 3 cases of the Whipple operation in 1935, it was all open. And that's how I trained, open. And that's how I continue to do the operation. Some patients that are of good body habitus and some skilled surgeons have now gone ahead and done successfully a laparoscopic or a robotic Whipple procedure. And my hat's off to them. I'm at the end of my career, and my learning curve to learn to do laparoscopic or robotic Whipples is not something that I intend to do. But there are places that do focus on selected patients, and that's the critical element here. Not everybody is a candidate for minimally invasive surgery or minimally invasive Whipple procedures.
What would make you not a candidate for a minimally invasive
Well, for example, the fellow we did yesterday where obesity, prior chemotherapy, prior radiation therapy, very, very inflamed and fibrotic tissue planes, such that and his size makes it impossible really to do a safe Whipple procedure. There would be the risk of terrible vascular injury, and it would also be almost beyond the limits of retraction to do a successful robotic Whipple on the fellow that we did yesterday.
And just educate me a little bit more. What causes someone to need this Whipple procedure? Is it you're at a certain stage of pancreatic cancer? Has there been metastasis? At what stage is someone a good candidate for the Whipple procedure?
Yeah, so the Whipple procedure is done not only for cancers, but also for selected benign diseases. There are benign tumors that grow in the head of the pancreas that we would want to take out so the tumor doesn't grow larger, cause problems with biliary obstruction or pancreatitis. But in pancreatic cancer, we operate on patients with gland-confined disease that has not metastasized to the liver, to the lungs, or other places. And there's really 2 groups of patients that we operate on currently. The first would be those who we do what's called a surgery-first approach, where we operate first, remove the tumor, and then it's recommended they receive postoperative adjuvant chemotherapy or chemoradiation. That's the first group. The second group would be patients who have either resectable, borderline resectable, or locally advanced disease, where the patients are recommended to have preoperative, pre-surgical chemotherapy or chemoradiation therapy, like the fellow we did yesterday. And then subsequent to the patient receiving several months of pre-treatment, we then operate.
Got it. And they get this therapy before the surgery in the hopes of maybe you get clearer borders, or it's smaller and easier to take out, or is that the hope?
Well, a couple things. Pancreatic cancer, when it's first diagnosed in many patients, is a systemic disease. Even though we can't identify living tumor cells by scan, there have been numerous studies that have shown that circulating tumor DNA exists in the bloodstream. You can find tumor cells in the bone marrow. So that's one rationale for preoperative therapy, that is to get systemic treatment in the patient before you go after the locally confined, the gland-confined disease. The other reason for preoperative chemotherapy would be if the tumor, based upon its proximity to the essential visceral vessels, and for the medical students out there, we're talking about the common hepatic artery, the superior mesenteric artery, the celiac axis, the superior mesenteric vein, the portal vein, those big blood vessels that carry a lot of blood, typically down to the intestines or back from the intestines towards the liver. If those blood vessels are involved with tumor, the tumor surrounding them, then we've learned over the last 3 decades that we're not going to achieve an R0 or a margin negative resection. And it's important to achieve an R0 margin negative resection to give the patient the best chance of long-term survival. Hence the rationale for pre-treating such patients with neoadjuvant therapy.
How new is doing this neoadjuvant therapy?
I remember, Zach, whenever I was in training, that the thought was, and this is probably in the late 80s, early 90s, that it was not appropriate to operate on patients who had received chemo or radiation therapy. It was thought to be too dangerous. And that was something that a few brave surgeons at the time, some of my colleagues at Johns Hopkins, embarked upon and began to operate on these patients and had very good results. Found that the risks to the patient were not as overwhelming as had been supposed. And so it's been a paradigm change, and it's a paradigm change for the better. Just one more little piece of knowledge is that when I first got interested in pancreatic cancer, which is now 30 plus years ago, the overall 5-year survival rate was 2%, which made it one of the most lethal and deadly cancers. As of just about a month ago, we announced that the overall 5-year survival rate had risen from 2%, and it's gone up gradually, but this year's data, it's 12%. Wow. That's a 6-fold improvement. We still have a long way to go because the 12% overall 5-year survival rate means that 88% of the patients are succumbing. So there's still plenty of opportunity for people to make a difference in this disease, but there's been dramatic improvements.
That's a fantastic improvement. I mean, what do you attribute these changes to? Is it this neoadjuvant therapy? Is it better chemotherapy or drugs or anything like that? What do you attribute it to?
So it's combinatorial. There's clearly multiple reasons for the improvement. Some has to do with improved imaging and better understanding of precursor lesions and operating on people before they actually have pancreatic cancer, but when they have a precursor lesion like an IPMN or an SCN or an MCN. That's one issue, better imaging. Second issue is much better perioperative management, anesthetic improvements, surgical technique, such that patients are able to survive major pancreatectomy with very low mortality rates. There was a time in the 1960s and 70s when 1/4 of the patients who underwent a Whipple procedure would die postoperatively from complications, and at that point there were people that said the Whipple operation should be condemned and should be prohibited. It should not be done. Obviously, we've made terrific improvements. So, imaging, better perioperative care and better patient selection, and then clearly advances in medical oncology, now some immunotherapy, radiation therapy, et cetera. So it's been combinatorial, but overall it's very gratifying. We still have a long way to go.
So people travel all over the country to have you perform this Whipple procedure. Why do you think that is? And how did you become the Whipple King?
Well, I would take issue with being called the Whipple King. I think I was the beneficiary of superb training and great mentoring. And I come from a school of surgery led by John Cameron, who I had the privilege of holding the first professorship in his name. And it was Dr. Cameron who really put the Whipple operation back on the map, along with a few of his contemporaries. And so I'm not the Whipple King. I am a Whipple, one
Prince?
of many princes.
Got it, okay.
I would say a prince, or maybe a duke, or something like that. Because there are many, many people across the globe who are really very, very good at doing this operation. You're right. I've been blessed, and there's many reasons for it, with a career where I have had people come to Philadelphia, before that to Baltimore, to have me do their surgery. And a lot of it has to do with some of it's word of mouth, some of it's the internet, some of it clearly is our work in defining the molecular genetics of pancreatic cancer. We had a very early NIH grant back in the early 90s. It was called Correlates in Treatment of Pancreatic Cancer. The NIH asked us they had put out an RFA, a request for awards, and we responded. We had the lowest score in the nation, which is a good thing, and that led us to getting funded by the NIH. And I was really I was sort of the manager of the team. I was not the star by any means. I pulled together bright young scientists at Johns Hopkins at the time, and we went from cytogenetics to basic molecular genetics, and we helped to define the common mutations in pancreatic cancer, with the hope that, better understanding the genomics of pancreatic cancer, we'd be able to identify actionable mutations such that we would find a therapeutic window for individual patients. This is sort of the forerunner of what now we take so for granted as personalized medicine. So I'm not the Whipple King. I've been blessed with having people come from all over, and it's gratifying. It also, though, raises the bar a little bit. It's when people travel a long ways, you want them to do well, and you pray that they have good outcomes. You want to take care of them properly, and a lot of what we've built is a team effort.
So you're clearly passionate, you've clearly had an impact, and I think you're clearly successful in your field. Let's back all the way up. In medical school, did you know surgery was the thing for you? I'm going to be surgery, I'm going to do this, all these kind of great things going forward. How did you know?
Yeah, Zach, I've told this story a few times.
Yeah.
But so if you look back at my high school yearbook, and you look back at your pictures and you look at yourself and go, "Oh my God, I look like that." But I wrote in my yearbook that I wanted to be a dentist. Why did I want to be a dentist? Because my best friend's father was a dentist. I didn't really know any doctors. I grew up in an apartment building in a duplex. When I was a teenager, my family first lived in a single-family home. My father worked for AT&T. My mom was a stay-at-home mom. So I really didn't have any real exposure to individuals that were in the medical profession. Every now and again I'd go to see a doctor for a sprained ankle or something. So high school, dentist. When I first got to Princeton, the first week, the orientation week, I saw some posters, and it was for the Pre-Dental Society. And I showed up at this meeting of the Pre-Dental Society. I walked into the room, and nobody really looked like me. Nobody really looked normal, I must say. And I thought, I'm not sure this is what I want to do. I mean, it was silly. It was silly. And then 2 days later, there was a meeting of the Pre-Medical Society. So I went to that. And quite honestly, at least a few of the people in that room looked like me. It looked like normal people. So I thought, well, maybe I want to be pre-med. But at the time I was doing athletics. I didn't know what I wanted to do. But eventually during college, I settled on a career. I knew I wanted to do something in a STEM field. I was good at science. I was good at math. So that's sort of the forerunner. Medical school. I felt so blessed to go to Johns Hopkins. I actually got in off the waiting list at Johns Hopkins, so I was not one of their top choices. But it was a place that really attracted me. I had met some of the faculty there, some of the surgical faculty, in particular a fellow named J. Alex Haller, who was a pediatric surgeon, and the history of Johns Hopkins really intrigued me. As a sidelight, the history of Jefferson's even older. Maybe we can talk about that later. But so at Hopkins, I loved everything I did. I really loved all the rotations, and it was unclear to me what I wanted to do. Many people had me going into orthopedic surgery. I think that's what happens if you're an athlete in the past, and they sort of pigeonhole you there. I didn't love orthopedics, and then I really got fascinated by complex medicine, internal medicine. And truth be told, as a junior in medical school, I actually solicited medical professors of medicine, to write me letters because I was thinking of matching in medicine, in the field of medicine. And then I had a change of heart during one rotation in Baltimore, where I went to the Baltimore VA hospital to do a surgical sub-internship. And at least in my mind, I thought that the surgical chief residents that I interacted with, and this is how individuals, at a formative time really can change the direction of your life. I thought these surgical chief residents were absolutely all-stars. They knew their medicine. They knew how to take care of common medical problems, but they could operate, they could fix things, they could get people better. And so then I had to weigh a career in surgery versus a career in medicine. And in my naivete, I thought, I know how to treat diabetes, because we didn't have many drugs for that back then. I know how to treat asthma. We had like one drug for that. We had theophylline. I know how to do the workup for delta MS. We didn't even have CAT scans back then. So I knew how to do a neurologic exam. I knew how to treat cellulitis. We had a handful of antibiotics. So in my mind, the field of medicine I had mastered. Now, here's how naive I was. I had mastered the field of medicine as a rising senior medical student, but I knew the field of surgery was going to be a challenge because I didn't know how to operate. So what I had to do was go to those medical professors sort of with my tail between my legs and say to these really famous medical doctors, I'm sorry, I've decided to apply in surgery.
Oh boy.
Please don't send that letter. Don't write that letter for me. And a couple of them tried to talk me out of it. But then I went on and applied in surgery, and I think it was clearly the right decision for me. So I didn't go to medical school thinking I wanted to be a surgeon, and I certainly didn't go to medical school thinking I wanted to be a Whipple doctor.
You think it was the experience when you were actually in the OR with those chief residents that said, you know what, I'm going to be a surgeon. That's what I'm going to do.
I think it was more than that. I liked the OR, although as a medical student, as you're probably familiar, Zach, you don't get to do very much.
No.
And back then, this was before minimally invasive surgery, so there's no laparoscopy. Everything was open, and the medical student's job, quite honestly, was to pull on retractors, oftentimes not even seeing the field. So, looking back upon it, I can't say I loved pulling retractors, but I did love seeing what was going on, the little glimpses I could get. And I liked the technical aspects of it, the detail approach, the fact that you could do something with your hands, and that you could take a person, for example, who maybe had an obstructing cancer of the right side of the colon, and, there's no medicine you can give that patient to make that tumor go away, and you can't shine an X-ray beam on and make it go away. And the patient has a bowel obstruction. You have to do something. So you have, it's like if P, then Q. You have a problem, you can fix the problem and move on. And that was, I think, very gratifying to me.
And you loved every single rotation. There was no rotation that you knew, right away, this is not for me. Because I know me personally, my neuro rotation, it was interesting, but I knew I'm not going to be a neurologist. This is not what I'm going to do.
I actually loved, now, we didn't have as many basic clerkships as you guys do now.
Okay.
But I must say, I loved every rotation. And I'll share one sort of personal item with you that psychiatry was something that I was sort of dreading. I actually loved my psychiatry rotation at the old Phipps Clinic. I was put on a ward which was a very innovative ward of individuals that had sexual dysphoria. And this is long before this is cutting edge sort of transgender surgery and people with that sort of that sort of mentality. And I found that very, very intriguing. And it turns out in my own personal life, decades later, I had a child that ended up being a female to male trans child. Not that I remember anything specific about my psychiatry rotation, but I have thought, along the way that, wow, it's hard to believe that in medical school I had my first experience and first introduction, if you will, to this topic, which was not well known at the time, and I played it out as an adult.
I can imagine it was cutting it. Were there other universities or locations doing similar things?
I'm not an expert on this, but I can tell you that the program at Hopkins at the time was clearly cutting edge in the U.S. There were a few places in Europe I know that also had expertise.
So let's get into residency. What was residency training like?
Yeah, so that's a broad question,
yes.
Obviously, Zach. And I would say things have changed dramatically over the last few decades. We used to joke that we were on call every other night. And the problem with being on call every other night is you, quote, missed half the cases, end quote, which is not really true because when you're on call every other night, it meant you were there during the day, basically every day. And yes, you got to go home maybe every other night to get maybe a few hours sleep. We joke about it now when I sit around and talk to my contemporaries and my peers because if you do the math, 7 times 24, that's 168. We had a duty hour restriction. We were restricted. We could not work more than 168 hours a week. It was not possible to work more than that.
And that was mandated by the school.
Well, no, that's simple math.
I know.
But nobody was checking your work hours. I mean, this is prior to work hours. And, I think, so you ask about residency. It was pretty brutal.
Yeah.
Residency was pretty brutal. And in our day, at many places, Hopkins being one of them, there was a pyramid. So right now we have most places, all places have a rectangular system. No matter what specialty you go into. But for example, in surgery here at Jefferson today, we take 7 categorical interns, and those 7 interns become PGY 2s, 3s, 4s, 5. They may do some lab work, but we bring in 7 terrific men and women, and we graduate those 7 people, typically 6 or 7 years later. That's a rectangle, right? It's a rectangular system. We had a pyramidal system. So we had 20-some interns who started the PGY 1 year, a few of whom were designated to go into ENT or neurosurgery. So it's not that all 20 were competing, but a good number of those 20 were competing for what ultimately were 3 super chief resident jobs. So there was a pyramid, and there was something called the cut. C-U-T, there was the cut. And the cut occurred after your 2nd year. And if you wanted to be a surgical chief resident at Johns Hopkins, you had to make the cut. And if you didn't make the cut, you would go elsewhere. And at the time, there were programs.
Other universities?
Oh, other universities had the same sort of a deal. Not all.
Yeah.
Not all, but and there were places where they would accept the Johns Hopkins PGY 2s, rising 3s, and they went on to get great training. And there were people I was interns with who've had incredibly successful careers, stellar careers in surgery, but who didn't make that Johns Hopkins cut. And so it led to a lot of competition. There was, you had to show stamina and enthusiasm and be a workhorse and be involved with writing papers and clinical. There was a lot expected of the people who eventually got selected by a process that I have no familiarity with, because by the time I was on the faculty, we had transitioned to a rectangular system. But it was, you asked about residency. It was an incredibly special learning experience. And we took care of patient after patient after patient. There was no quota on how many patients you can have on your service. I vividly remember, if I was on the cardiac service and they were going to do, say, 8 open cardiac operations the next day, I was on call that night, I would do 8 histories and physicals. The patients would come in the night before. One person, me, would do 8 H&Ps in the evening, and you got very good and very efficient at doing H&Ps so that the patients would be ready for the OR the next day. And that was just part of what you were doing on that evening that you were on call, because you also had to take care of the patients on the floor and the patients in the cardiac SICU. So, it was a very, very intense, quote, training program, but also doing things that the residents don't do now.
Do you think this competitive nature, this intensity of a training program is a good thing? Or do you think comparing it to now, it's better now?
Well,
or if you can give me pros and cons.
Yeah, I'm glad that we have progressed beyond the training that I endured.
Yes.
Having said that, I am delighted that I trained in the era that I did, because I think I learned lessons and had experiences that were really unmatched. But now I'd say, and I think we have one of the top surgical residencies in the country here at Jefferson. Now I'd say there's far more collegiality. There's far more out-of-hospital human activity. If you ask me about, for example, I'm a music lover, you ask me about the music of the late 70s and sort of early 80s, it's a little bit lost on me because I was not listening to the radio.
Yeah.
I wasn't home. I wasn't, if you ask me about movies from that era, I couldn't tell you about it.
Yeah.
It's a little bit of a lost era for me. And I think now the residents, they work hard, they get great training. They're trained in laparoscopy and robotics or intensive care. I mean, training is so much more focused on them, but they also have a better opportunity for personal lives and for, being human.
Yeah, yeah. And we can skip this question if you don't have any specific answers, but do you have any particularly memorable experiences when you're doing your residency at Johns Hopkins? Anything that stands out in your mind?
There are many things that stand out. Two things that come to mind. I was present in the Hopkins emergency room when a patient took a weapon, a handgun from an officer, and shot the officer 5 times, and then the officer wrestled the weapon back and shot the assailant, the patient, 1 time. So that's fresh in my mind because of the incident we recently had at Jefferson, where there was a shooting in the hospital. I mean, those are things you don't forget. And that happened during my JAR year, my junior assistant resident year, which is PGY2. So, and that was in the ED. Another amazing recollection I have is of a white Cadillac convertible with red interior. So picture this now. A white Cadillac, red interior, drives through the doors of the Hopkins emergency room. Back then, the Hopkins emergency room was up a little ramp, and there were these double doors, glass doors that opened, and the Cadillac literally comes through the doors, going relatively slowly, and stops. And I happened to be on call in the ED that night in the emergency room, what we called the ACS, the accident room. And the fella who was driving the Cadillac had been stabbed in the heart. And he had a single stab wound to his chest. it happened a few blocks away from the Hopkins Axe. He drove himself in his Cadillac to the Hopkins Axe and then sort of passed out on the way up. Fortunately, his foot sort of came off the accelerator. So he basically self-delivered himself to our emergency room where we operated upon him and saved his life, brought him upstairs, median sternotomy, and we closed a single stab wound to the right ventricle. For the medical students, again, the right ventricle is the anterior-most part of the heart, and when you get stabbed anteriorly, it usually goes through the RV because the LV is posterior, and that was a great save. That was an absolutely great save, but, thinking back upon it, you almost have to have that scenario in order to save somebody with a stab wound to the heart.
So you're saying if we get stabbed in the heart, we should drive our car through the emergency room doors.
Please don't do that.
That's amazing. And so, that's crazy. And then the shooting in the ED, when that happened, did you guys rush in and kind of try to do something there? Or
we did. We heard, it was interesting. We heard 5 shots, pow, 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 pow. Then a little bit of a delay, a little gap, and then pow. So we counted 6.
Yeah.
And the Baltimore police officers carried weapons that had 6 bullets in them. So, yes, we all ran.
Yeah.
Ran to it. We ran to it. We're there to help people.
Yeah.
And quite honestly, it was amazing. Both of the individuals did not survive. The police officer with 5 bullets in him actually survived longer than the other guy, because when the police officer got the weapon away from the assailant, from the patient, he hit him in the chest, and it was a bad injury. When the patient shot the cop, there were some extremity injuries, and I've never seen such an outpouring. You see it on the news all the time, but they quickly ran out of blood in the blood bank, and they asked for more blood, and hundreds of Baltimore City police officers came to the blood bank to donate blood. I mean, within hours, there was a line of people, police officers donating blood. So that was a real tragic event.
But that's amazing that all these people would come together to kind of help someone. It almost speaks to the hospital and your career, right? Our career. It's this kind of amazing thing of people coming together to help other people. I think it's fantastic. So let's go more into your specialty, right? So you're in residency. Do you find a passion for kind of these pancreatic procedures and the biliary system during residency, or is it kind of your experiences afterwards?
Yeah, it's very much the latter, Zach. So again, sort of as a medical student, I really enjoyed everything I did in my training, from ENT surgery to thoracic surgery, vascular, GI, thyroid, parathyroid, et cetera. And in that era, it was less common for people to do fellowships. I didn't do a specific ACGME-approved fellowship, although my super chief year, which we called the Halstead resident year, I did 6 months of advanced GI surgery, but I also did 6 months of advanced vascular surgery. So whenever I graduated from my residency program, my little certificate, for what it's worth, says I was a general and vascular surgeon, and I had competency in thoracic surgery as well, at least in the mind of my mentors. And for the first few years of my career, I was focused on being a clinician scientist. I wanted to have a career in academics. I heeded the advice of my mentors, thinking that leadership was something I wanted to do. I was very much involved with education. I was the educational coordinator for surgery and the curriculum consultant, and that was great fun for 17 years or so. But my early clinical work spanned doing thyroidectomy, mastectomy, fixing hernias, operating on gastric cancer, colon cancer, doing fempop bypasses, fixing abdominal aortic aneurysms, and every one of those operations. So you can see that spans a huge practice. All those operations are done open, And I enjoyed doing all that and doing the teaching. And I had a laboratory that I was studying GI hormones based upon my experiences with Downstate Medical Center, and again, some of my mentors, people like Mike Zinner and others. But what really changed my career trajectory was something I alluded to previously, Zach, and that is the NIH back in that day, every 2 weeks would put out something in paper, because this is before the internet. They would, and it would come to your office, and it was the NIH guide type thing. And in the NIH guide, I saw the RFA. I saw that the NIH had set aside monies in about 1990 to further study pancreatic cancer. They recognized pancreatic cancer as a disease that needed attention. And I was not working on pancreatic cancer. I had operated on very few patients with pancreatic cancer in my training, although Hopkins had, John Cameron had become the chief, and he was building a huge practice. So I actually was very intrigued by the opportunity to submit a grant that was completely outside my expertise. And I did what any, I would say, I did what any manager, what any, not quarterback, because the quarterback is skilled. I did what anyone at Hopkins would do, I think, and that is I reached out to the young stars that I knew in pathology and medical oncology. And we had a couple meetings. This is way before Zoom, so we did all the meetings in person. And I found that there was interest. And the reason why there was interest was because Bert Vogelstein and Ken Kinsler had put the molecular genetics of colorectal cancer on the map. And we got together a few times and we said, we could do the same thing. We could basically duplicate what they've done for colorectal cancer, only we could do it with people who are in their 30s as opposed to people who are a generation older. And then somewhat sheepishly, I went into my chairman's office, Dr. John Cameron, and I said, Dr. Cameron, I noticed this in last week's NIH guide. There's a pot of money that the NIH is offering for pancreatic cancer research. I've put together a team. I'd like to submit a letter of intent and then submit the grant. And John looked at the materials and said, go for it. And we did that. You know, we submitted the letter of intent. We wrote the grant. I vividly remember driving that grant down to Bethesda from Baltimore. And I think you had to submit something like 30 copies of the grant. So, you know, you have a document that's 1 inch thick. This is before, you know, PDF files. So you take that document, you make 30 copies of it, you collate them together, you put them in a big box. And of course, you know, we didn't have this grant ready 2 weeks before the deadline. We finished the grant the night of the deadline. And it was due down there the next day, so I drove the. Who's going to drive it down? You know,
it's also gold, right? It's
car service. You know, so I drove the grant down. I double parked in front of a building. You know, all the buildings at the NIH have numbers, so it was like, you know, building, I forget, 42 or whatever. I'm making that up. Double parked, walked in, carrying my box. There was a table there. It was like a sort of a gymnasium type thing. And I said, I'm here to submit my grant, thinking they were going to, you know, welcome me.
Bow down, yes.
And the guy turns and says, put it over there in that pile. And lo and behold, there was a pile of, you know, hundreds of grants. Now, it just wasn't this pancreas grant. This was an NIH deadline. So, but there was a pile of boxes and containers of grants. And he just said, put it over there. You're good. And that was a little bit disappointing, you know, concerning, because I thought, oh my God, there's no way. But drove home, and you know, then you wait months and months, and we had the best score. We had what you know in NIH parlance was the lowest score, so we had the lowest numeric score, which was the best score. We were fully funded for 5 years, and that changed my career. That clearly changed my career. So. That's how really I developed my focus on pancreatic cancer. It had nothing to do with high school, college, med school per se.
And at what age did this happen? This kind of it's not a career switch, but it's a different angle. It's not a 180-degree turn, but maybe it's a 15-degree turn.
So doing the math, I was 37.
Wow.
Yep, 37.
37. And so you start doing this. You're given the grant, you start doing the research and all these kind of things. And do you find yourself enjoying it?
Yeah, it was really transformative. We had regular meetings. We focused on trying to correlate findings we had molecularly with patient outcomes. We were in the process of starting a number of prospective randomized trials, which I had the privilege of either working on or being the PI on. And that really was, I think, paradigm changing in the field of pancreatic surgery and in the treatment of pancreatic cancer patients. So it was really a very, very important time in my life. And I'm very grateful that I had the opportunity to do that.
So the grant comes to an end, where you said 5 years it was, right?
Yeah, we renewed it.
Got it.
We renewed it, and then we got a SPORE grant, which is a special program of research excellence. And the grant continues at Hopkins to this day.
Wow.
And the people that worked on that grant, some of whom have retired, the initial people, a few people have passed away, but it spawned a whole generation of pancreatic cancer researchers, not only at Hopkins, but here at Jeff and other places where people have gone on and have interest in pancreatic cancer and continue to be funded to this day. So it was a good thing that we did.
And was there ever a moment, ever a thoughtful decision, I'm going to continue going down this path, I like this path, or maybe I'll go back to what I was doing before, or was it kind of you just kept taking one foot in front of the other? Because I'm wondering, because this is a big career move, I think, right? And I'm wondering how you come to this decision, or if there's any thoughts about making this kind of decently big decision about your life.
Yeah, I mean, so I think you rely upon your own judgment and the judgment of your mentors and people who you really respect. I would say that even after receiving the NIH funds, I continued actually to do mainly alimentary tract surgery. I would do an occasional breast operation, mastectomy. I limited my practice. I stopped doing vascular surgery. I continued to do inguinal hernias and ventral hernias, for example. When I got the opportunity to come here to Jefferson in 2005, a person that I really respect and admire sat me down and talked to me about what it meant to be a chairman and what it meant to lead men and women and how much gratification you could get out of that. And he told me something that I'll never forget. He said, Charlie, you really are a good surgeon. You love operating, but if you're going to be a chairman, you need to narrow your focus surgically, and you need to not be. He didn't use the word sort of discombobulated or frenetic, but that was what he meant. That I needed to focus on one specific area of medicine because I was going to have a lot of responsibilities in education and administration for a department. And so I heeded that advice. And you decided, this is the thing I'm going to do. I'm going to focus on these alimentary procedures and things like that. I'm going to focus on that.
On
the HPB procedures.
On the HPB procedures. That's a better way to say it. And we learned what that is. So now I can say that. That's perfect. And just, again, because I'm naive on this field, how do you go about, as an attending, kind of making these decisions? Do you say, only schedule these cases for me? Do you say, I'm only doing these procedures, don't do these procedures, don't give me patients that, have kind of an AAA or something like that?
Yeah, well, so that's a bigger question about how you orchestrate patient inquiries about diseases, right? And so we have online scheduling. We have schedulers. If someone calls and says they want Dr. Yo to take out their right lung, my clinical coordinator would say, well, Dr. Yo doesn't do that. And we have special templates. So you want to operate within your field, and we have many of our faculty now are specialty trained. Even though they may have trained in general surgery, they've gone on for additional specialty training, and they do limit their practice to certain things that are within the area of their expertise, their knowledge base, et cetera. So that's not as big a problem. As a chairman, really not a day goes by where I don't get an inquiry from someone, typically someone I don't know, that says, my mom has X. Will you see her, or who would you recommend? And that X could be a medical disease, it could be a urologic disease, it could be a cancer, it
Wow.
could be a surgical. And so that's just, you rely upon your network, and you answer every one of those, and you refer the patient to the proper Jefferson expert. But not a day goes by that doesn't happen.
Go into your career nowadays. Can you take me through an average week of what it's like to be a chair of surgery? What days are in the clinic? What days are in the OR? What days are administrative?
Typically I operate 3 days a week, Monday, Wednesday, and Friday. As we discussed earlier, the operations usually take somewhere between 4 and 10 hours, so you have to block out quite a few hours. I start my operating time usually around 7 o'clock. Realistically, that's anesthesia, preparing the patient, so the operations don't start till 8. You sign the patient in at 6:30 a.m., get to the hospital around 6 a.m., and get up around 5 a.m. I'm able to do meetings between 6:30 a.m. and 8:30 a.m. or 8 a.m., so I can get some meetings done in the mornings, and then many of the meetings I do are in the afternoons after the cases. Personally, I see patients 1 half day a week. That's Thursday mornings. It just happens to be the day that I do it. And then on Tuesdays, usually I stack most of my administrative meetings. I'm able to orchestrate that. Whatever meetings I have a little bit of control over, I typically can orchestrate that way. So I'm in the hospital Monday through Saturday. When I'm in town, I always come in on Saturdays. I love making rounds and doing teaching rounds on Saturday mornings. There's not the hustle and bustle of getting to the OR, and then I can sort of clean things up. Every Sunday morning I work at home. I used to be in the hospital 7 days a week, and I think because biblically we're supposed to rest 1 day of the week, my wife convinced me that it was that going into the hospital 7 days a week is sort of too old-fashioned. So I did acquiesce to her suggestion.
Say, when did this happen? When did you start taking a day? So for how long you have not been taking a day off?
Oh, I mean, that was residency and junior faculty. And because we didn't cover for each other, we always went into the hospital and saw our own patients. We always had patients in the hospital. So, that was very, very, very common. That was the way most people did it, quite honestly. But at least for 10 years now, I've enjoyed my Sundays off. Sundays off, working for a few hours in the morning, just because, that's the time that you can edit papers and chapters and be creative and plan for the administrative duties of the next week, because there's a lot that goes into caring for patients, but also caring for your residents and caring for your faculty, because it's a big lift. It's a heavy lift, recognizing that faculty have come to Jefferson to work in your department. You want to make sure you help their careers. You can mentor them appropriately. You can get them into the right organizations, and also it's a wonderful, wonderful leadership position.
This is an amazing work ethic. Do you attribute this to anything, to your parents, to kind of maybe a mentor when you grew up? Because this is unusual, I think. Many people, they work from 9 to 5 and they have the weekends off. Of course, we're in an unusual career, right? This healthcare field, but 7 days a week, always on for a while. Did you attribute it to anything? Is there anything that you say, listen, these people, my parents taught me this way, so this is just the way it is? Or what's going on here?
In my mind, it's not all that unusual.
Okay.
I must say. Now, my father was an executive. He started as a lineman for the Belltel telephone company and rose to be an executive for AT&T, mandatory retirement 65. My mother was a really a lot of personality, a Greek immigrant gal, and Greek was my first language. But I don't think the work ethic is that unusual. At least not the way I was brought up. In the sense that, and I don't mean just my parents, but I mean by my teachers and my mentors and my professors. and my fellow colleagues, because we were all pretty driven, and we were all had a little competitive bug in us. And quite honestly, what I said before, if you're on call every other day, you only miss half. You miss half the cases. Not sure I wanted to miss much in the hospital. Plus, you're running a lab, but you had to go in and check on the experiments, et cetera, et cetera. So I didn't find it all that unusual.
Wow. So let's talk a little bit more clinical, and then we'll get into what it's like to be a chair. So you clearly love it. I mean, you can tell by this work ethic and everything like this. What is the best thing about being an HPB surgeon?
There's a couple components to it. I think the ability to do a complex procedure and have a good outcome is clearly a very motivating factor. A procedure that not everyone in the world is capable of doing, and even some expert surgeons. So that's one thing. The other thing is it's a great opportunity to teach the fellows, the residents, some technical aspects of surgery and how to focus on attention to detail, recognizing that the patients are putting their life in your hands, and that's a very special relationship. The other thing that makes it very satisfying for most patients is that we're able to accomplish something that provides them hope. And there's a saying that the Pancreatic Cancer Action Network has promulgated, wage hope. So we, in a sense, peddle hope, and not in a nefarious way. We give patients the opportunity to be cancer-free, either forever or for years and years. And that, I think, is and you also see the gratitude on the faces of the patients and the families. So it's an incredibly satisfying field. I've had the opportunity to operate on children, on teenagers, on nonagenarians, even one centenarian, somebody over the age of 100, do a complex pancreatic case. And so it does span a wide degree of ages, and you can do a whole lot of good.
And the counter question, of course, is what is the worst thing about being an HPB surgeon?
Yeah, I mean, I guess there's two elements of that. One element is it certainly takes a toll on you physically, standing in the OR for 10 hours, 3 days a week. So I think you have to be physically fit and keep yourself in good shape. And, you don't see many short of breath, arthritic people doing HPB surgery. So you have to have maybe good genes as well.
Mm-hmm.
So there's a physical toll. The mental toll really comes from the patients who succumb. And, the mortality rate from the Whipple operation in our hands at Jeff is about 1%. That's a very low mortality rate. But if you're the one of the 100 that dies post-op, you're 100% dead. And I think many medical students and even residents don't recognize that when we take on these patients, we form a bond with them, and we want them to do well. And every operative mortality you have, I think, weighs on you. I've kept a list over the years. I have a little, essentially a spreadsheet of the names and the ages and the operations of people who I've done the Whipple on that have not made it, that haven't survived out beyond 30 days. And there's 20-some patients on that list because I've done about almost 2,000. So there's 20 patients or so, and I look at that list every now and again. Of course, I add to that list every now and again as well, and I recognize that I personally was responsible for shortening the life of some humans. You balance that with the fact that 99 patients survived, and I got a letter this week from a gal who is a 19-year survivor, and she sent me pictures of she and her husband in front of the Christmas tree. So I think you have to balance, the fact that you can help people that they're grateful, and with the fact that what you do is serious business and you can cause harm. You don't do it intentionally, but things can happen and patients may not survive. So I think that's one of the hardest things.
Do you remember your first complication ever? And is this how you mentally dealt with it then?
So on my list, I have my first, and I do remember that patient. I remember the complication. And I'm not sure that patient would die nowadays because we're better at rescuing patients. But sure, I mean, now, I don't remember each of them individually without prompting by looking at my list. And I think that's sort of human nature. We tend to sort of step behind tragedy and look for positives.
And when that first complication happened, how did it affect you? Did it have a significant effect on you, or was it kind of...
It clearly affected me, and
Yeah.
my wife can speak to this because she
Yeah.
knows whenever I have a patient that's not doing well,
Yeah.
I sort of bring that home with me, and she also hears the phone calls at night, and so it becomes sort of a family, a family issue as well. And when the kids were younger, this same thing, they would know that
Yeah.
Dad has a patient really sick. You basically you try to learn from each of these experiences, and you try to move past it, and you hope that that the lessons you've learned you can put into practice and make it so that the next patient doesn't have the same trouble. But and let's face it, people walking on the street have MIs and strokes. So it's one thing if they die of something that's not related to your surgical procedure. It's another thing where you can see yourself in something that you've done as the proximate cause of their demise. And I think that's what some people struggle with. And that's where you use your family and your friends. And we have a program here called RISE that you may need to talk to a colleague about it and have a cup of coffee. And I've done that with some of my junior faculty. So.
And is this the advice you would give to junior faculty residents when they go through their first
Share
ever
your
complication?
turmoil.
Share your turmoil.
Share your turmoil. Talk to someone about it. Have a conversation, recognizing that we've chosen to go into a field that is not all upside. And quite honestly, Zach, that has the discussion we're having right now clearly influences specialty choices amongst surgical trainees. For example, if you are an individual that does not do well with complications that can lead to death, then there are some specialties that you can choose. For example, thyroid and parathyroid surgery is generally not surgery. It can lead to certain complications, hematoma, occasionally wound infections, recurrent nerve injuries, funny things with the voice, but patients don't typically die from your complications. Ditto, for example, for melanoma surgery, for example. Breast surgery would be another example. On the other hand, trauma, HPB, transplant, burn surgery, those patients have terrible physiologic abnormalities. They're undergoing major procedures, and a percentage of them are going to die. No matter how good you are, patients are going to die.
Wow. Well, that's very helpful. I think share it with others, I think, is great advice. Now transitioning a little bit. Now you're the chair of surgery. You've been the chair of surgery for a decent amount of time. How is this different? Is it what you expected being in this significant leadership position, right? Was there anything unexpected about it? Were there things that came up? You're like, wait a second, I have to deal with this as the chair of surgery? Anything at all about this position that was kind of new or you didn't expect?
Well, I had the opportunity to be a division chief of a division of 20-plus people at Hopkins before I came to Jeff. So when I came to Jeff in 2005, the size of the department was about the same size of my division at Hopkins. So size-wise, it was about the same. But the opportunity to lead a department, I think you can't underestimate what a great honor that is. And, I was so honored to be offered the job as the 8th Samuel D. Gross Professor, one of the iconic historical figures in American surgery, the so-called Emperor of American surgery. But to get back to your point, so it's a job beyond the clinical job. The administrative job is always there. You need to be available 24/7 to help the staff, the residents, the faculty. You need to be available for unexpected moments, disasters, crises, whenever the hospital goes on alert, whenever there's an active shooter. So no question that it's not like a banker and at 5 o'clock you can walk
Clock
away
out.
and by 9 o'clock the next morning you'll be back and whatever happens at night happens. So that's an important element of it. And with that comes incredible responsibility. The incredible upside is you get to help very, very smart, motivated people who have worked really hard to get to where they want to be. And I'm talking about faculty and residents. You help them turn the page on their life and have a successful career. And you get to see them get married and have children and raise families. And that's it's almost been, now I'm in my 18th year. It's wonderful to see a community grow around a department. And that's something that really provides not only me, but my wife a lot of pleasure as we've seen these bright young stars grow and mature and have families and go on with their lives. So there's a lot of really positive aspects of it.
It seems like you've chosen to work in academics, in an academic institution as well. What do you think are the best things about working in academia, I guess? And it sounds like this is one of the reasons, being with these amazing students, these residents, these faculty.
Yeah, I quite honestly, I've never been in private practice, so I'm the wrong person to ask for the dichotomy, although I have friends and I think I understand it somewhat. We are so blessed to be able to watch college students become medical students become residents, to light a fire, to see people get really excited about some element of their career. It's fun when a faculty member gets a grant or gets an award, or gets married or have personal things. It's incredibly gratifying to see residents and faculty present at national meetings, to have hot peer-reviewed publications, to have had a couple faculty write books of their own, to see them contribute to the literature, become authors on their own. These are the things that really make it all worthwhile, because not a day goes by there isn't some problem that gets brought to your attention, and so a lot of it's problem solving. But you have considerable autonomy. It's Atul Gawande, I think, writes about what makes things satisfying, and autonomy, complexity, and some sort of relationship between effort and reward, and those are three elements. And I think there's a lot to be said that as a leader, you have autonomy, you clearly deal with complexity, and you can see reward being linked to your own effort and the effort of others.
Now, being a leader, interacting with residents and medical students all the time, 2 questions. What are the best medical students like, and what are the best residents like?
There's probably not a whole lot of difference between the answers to those questions,
okay.
right? I think being present, being enthusiastic, being knowledgeable, being willing to learn, and then recognizing the incredible honor it is to care for another human being. Now, you can add to that and say, writing a paper, working on a project, doing research. I mean, all those things are additive, but I don't think you can discount the sort of availability, presence, enthusiasm, knowledge, technical skills, et cetera, et cetera.
Got it. And say you're a third-year medical student and you know for sure surgery is the thing I want to do. I'm applying into surgery. In your experience and with your advice, what do you think is the best things they can do to become the most competitive, the most wanted applicants into a surgical program?
Yeah, so, win a Nobel Prize and get an NIH grant. Obviously, so I think you have to step back a little bit from that question, Zach.
Okay.
Individuals, so there are dozens and dozens of excellent surgical training programs in this country. And as I always say to our medical students, and they're not all in the Northeast, and they're not all in the Philadelphia region. So one of the big things is, have a broad geographic goal. Be willing to step outside of your comfort zone. What makes for a good medical student on paper, and then it's the Zoom interview. And by the way, there's this thing called the match where a computer's going to match you up. So this is the first time for many of you. You're a senior medical student now. You're going to undergo the match soon.
Scared.
A computer's going to tell you where you're going. This is not your choice. Now, yes, you're going to compose a list, but that list, not everybody goes to number one on their list, as you're well aware. So for a third-year medical student, academics matter, clearly. We used to say board scores mattered, but we're going to pass-fail. So, that's going to be, obviously, most people are going to pass. I mean, it's going to be a rare, it's going to fail. Your exposure to surgery and surgeons such that you can get good letters of recommendation. For many of us, your work in the community, socially responsible things, so showing some empathy for social issues, and then clearly, particularly if you want to go to an academically structured program, a program that you'd be more likely to end up in an academic job, have you participated in research projects? Do you have publications? How many of them do you have? What level of it? By that I mean a case report is on the lower end of the scale, working on a large project with, prospective randomized trial or a meta-analysis better. So I think those are the elements.
Got it. Who is your favorite historical surgeon?
Yeah, I would say I'm going to pick two.
Got it.
Because of my background, and this won't come as a surprise to people that know me. Number one, obviously, I am the 8th Samuel D. Gross Professor. Yes. I've learned a lot about Samuel D. Gross. I've read his 2-volume autobiography. It's an unusual person that writes a 2-volume autobiography. So Dr. Gross was an amazing figure and a nucleating figure in American surgery, even though he shunned Listerian antisepsis, but scholar, amazing person. So Samuel D. Gross, and then William Stewart Halstead, who was the first professor of surgery at Hopkins, who really built the Halstead surgical training program, who had a very difficult personal life, who first experimented on topical cocaine, became addicted to cocaine, switched his addiction to morphia, and yet is revered by many as one of the ultimate detail-oriented surgeons who operated in a time when anesthesia was present so that he could be slow and meticulous. So I would say it's Gross and Halstead.
Wow. Should I pick up volume 1 or volume 2 or both?
Volume 1's probably the more interesting.
Next question I have, do surgeons have a responsibility to advocate for social change? And are there any certain changes that you would like to see?
So, I would argue they do, although clearly some people are reluctant to get involved with social issues, and I got that. But certainly I believe that it's important for most surgeons to be involved, to be socially responsible. And a good example is in our department now, we are joining a relatively new group called Socially Responsible Surgery. We're going to have a chapter here at Jefferson. And, what are the important topics? Well, women's health issues, incredibly important. Gun violence in America, particularly on the heels of what just recently happened in California, Half Moon Bay and Monterey down in L.A. And, so these are top. But also, beyond gun violence, geriatric falls and protecting athletes, so concussion, brain injury, helmets. There are many elements. We have the Jefferson Center for Injury Research and Prevention, headed by Stan Miller. It's a great area that students could get involved in. So yes, I mean these are important issues, and also there's the political climate in America today. And I won't give away my politic necessarily, but I think it's important that that surgeons play a role in at least their local politics.
Got it.
And that they vote.
And they vote. A vote. I think I definitely vote.
Yep.
Definitely vote.
Yep.
Any advice for graduating medical students who are about to be practicing physicians for the first time ever? This could be even directed towards me, because in a couple months in July, I'll be a practicing physician for the first time ever. Anything we should think about or have in our heads as we begin treating patients as MDs?
Yeah, so, it is an incredible blessing to get to go to college, get to go to medical school, and then do a residency in any field, because there are many people who wanted to be, Zach, where you are right now, who didn't make it for whatever reason. Number two, the physician-patient bond, as Osler talks about, is a very, very important bond, and one that you shouldn't dismiss at all. That's number two. Number three, it is incredibly important to keep up with the literature, to understand new advances. When I graduated med school, I asked my dad for a new car. He said, no, what's your number two on your list? I said, I want a subscription to the New England Journal of Medicine. And he bought me a one-year subscription. Back then it was like, $3 or something. It's hundreds now. But, I'm a surgeon, and yet I have read the New England Journal cover to cover every week since I graduated medical school in May of 1979. And that's important. I think it's important, whether it's the New England Journal or JAMA or Lancet, or whether you do it online, through some sort of listserv or whatever. I think you need to keep up with the literature. Number one, it's helpful at cocktail parties when people ask you about things, and I've learned all about AIDS and Ebola and COVID. And just keep up with what's going on. I think, the responsibility is yours to have an incredible fund of knowledge and make sure that you're keeping up as best as you can. Those are some of, and then please understand that in order to serve your patients well, you must be healthy yourself. So don't neglect taking care of your teeth, your body, exercising, eating healthy, etc.
Awesome. So very important question here. How is surgery like basketball?
Yeah. So, people joke there is no I in team, right? There's no I in the word team. There's also no I in the word basketball, and there's no I in the word surgery. So I would say the team sport, the analogy is very clear. When you play basketball, you walk from your dorm, from your house, you go to a locker room, you put on a uniform, and you go out and you work with people. When you're a surgeon, you go from your house, you walk into a locker room, you put on a uniform, happens to be scrubs, it's not short shorts, thankfully, and you work with a team. And so there's an awful lot of similarities, recognizing that there's no I, and there's no room for sort of prima donnas or people who refuse to be part of a team. And there's a great book, one of my favorite books in the whole wide world, written by the Hall of Fame coach at Princeton, a fellow that just passed away just a few months ago, Pete Carrill, who tried to successfully recruited me to go to Princeton. I wasn't good enough to play very long, but he wrote a book called The Smart Take from the Strong. The Smart Take from the Strong. And it's a wonderful little book. Has little anecdotes in it. Pete was famous for his little sort of aphorisms and sayings. And one of the things that at the end of the book, there's 25 little things to remember. There's a list. I'm sort of a list guy. There was a list of 25 little things to remember. And one of the things on the list was you want to be good at things that you do often. And I always joke, if you're the best person in the world for fixing make something up, an RV aneurysm, but there's only one of those in the world every year, who cares? So you want to be good at things that you do often. And then the other really important issue in basketball, fundamentals are very important. Basic, dribbling, passing, seeing, cutting. So you want to be good at those things that you do a lot and pay attention to detail. So a lot of similarities.
That's amazing. Well, this has been fantastic, Dr. Yo. I have one last question for you. If you have any closing words whatsoever, maybe for medical students that are interested in surgery, maybe for healthcare practitioners in general, maybe for people who are interested in Philly sports and watching what's upcoming soon, anything at all whatsoever, Dr. Yo, as we close out here.
Well, I'll certainly be rooting for the Eagles coming up against the Niners, and I hope that the Eagles can make it into the Super Bowl and win their second. I'm a big sports fan. I was in the stands when the Phillies won the World Series in 2008, and that was exciting. I was in Kenya with my wife whenever the Eagles won their Super Bowl. But sports are something that unifies us all together. So, clearly it's important to have interest outside of the hospital, whether it's sports or art or music or, reading. Zach, I see the books that are over here on your stand. You have a whole shelf of things that you're planning to read.
Yes, the top shelf are the things I'm going to read, and the bottom shelf are things I have read. So the top shelf, as he pointed out so nicely before.
A little bit larger than the bottom, but, you've read some good stuff. Be well-rounded, be well-rounded, and have passions outside of medicine, clearly.
Thank you so much, Dr. Yo.
Thank you for giving me the chance to do this.
I appreciate the time. Thank you. Perfect. That was fantastic.